Care policy and care in Japan, and the challenges we are facing and strategies. First, I'd like to introduce the Japanese situation. Japan is one of the most aged countries in the world. The aging ratio is 30% now and will reach 40% by 2050. Demographic structure is entirely different from India at present. But aging is an urgent global issue, so I'm pleased if my presentation helped to prepare for the future. Along with the aging, the number of people living with dementia is 4.5 million and people with MCI is 6 million now. Next, this is the overview of Japan's history of policies for older people and dementia. We established basic social protection such as universal health insurance and universal pension in 1960s. The upper half in blue is the policy and initiatives for elderly as a whole. The lower half in pink is for dementia. The first government measure for dementia was in 1987. I divided this history into three parts and discuss. This is the phase 1 before 2000. In this period, dementia was named Chiho in Chinese character. It means stupid and insane and is a discriminatory name. Care was considered each family's obligation, and there were extremely limited social services and no medical treatment. Under these social circumstances, family carers hit people living with dementia as a family's shame. Their last resort was institutionalization, such as psychiatric or elderly hospitals, where restrictions, lifelong admission, and social exclusion happened. Left side photo is from Kazuo Okuma's book, The Report of Elderly Hospitals. He is a renowned journalist in Japan. The right side is Dr. Hayakawa's word when he visited his patient. He is one of the founders of Alzheimer's Association Japan. His word, I found patients with dementia who were locked in horrible compartments in their houses. I felt deep sorrow and pain for both patients and their families. Let's move on to the second phase from 2000 to 2023. This is the period of development in dementia care in Japan, and many initiatives are implemented in the public and private sectors. Around 2000, person-centered care was introduced to Japan. It had a significant impact on dementia care. At the same time, the long-term care insurance law was implemented in 2000, and it declared advocacy for people living with dementia. Also, the national dementia plans were implemented. Training programs based on the person-centered care theory are promoted. And the Dementia Supporter Campaign, known as Dementia Fund globally, started. The number of supporters has reached 14 million in this year. In 2005, Japan changed the name for dementia from derogatory word to descriptive one. It greatly contributed to reducing the stigma and changing the social perception of dementia. Also, people living with dementia started to speak out to society through their own voices. Their voices have been driving forward to dispel misconceptions about dementia. Such accumulated steps came to fruition in the establishment of Dementia Basic Law in 2023. Among institutions in the period, initiatives in this period, I will add a brief explanation about the long-term care insurance, the Dementia Basic Act, and introduce the ongoing achievement of people living with dementia. First, I will talk about the long-term care insurance implemented in 2000. The long-term care insurance system supports people in need of long-term care due to aging, among other factors. The purpose is to support people who need care themselves and not caregivers. But it has improved the quality of life of people living with dementia and also the care need and also their caregivers significantly. It has been successfully operated for 20 years. However, the problems start emerging. I will talk about them later. Next, the Dementia Basic Act. This act is a principle of all dementia policy and measures. National policy is essential for dementia issues because dementia is not only an issue of medical and care, but the entire lives, such as work, shopping, banking, transportation, etc. It relates to all aspects of life. Through our 40 years of experience, I would like to emphasize the importance of national policy. The goal of the Dementia Basic Act is inclusive society. There is a four key points. 1. Stakeholders participation. 2. Integrated approach. 3. The responsibility of government, service providers, and citizens. And 4. Governance by the Cabinet Office. Next, the current active movement of people living with dementia. Medical development has enabled early diagnosis, allowing people to take an active role with a supportive environment. Based on dementia basic law, both public and private sectors are responsible for supporting it, and their voices have grown increasingly powerful over time. Of course, we are still at the starting point of inclusive society. Even so, it may be said that we have developed dementia care to a certain level. But at the same time, we are facing the following serious challenges. Let's move on to the phase 3. Further and rapid aging impact all aspects of society and of course on dementia care. Example of impact are living alone or elderly couple household, older carers, long distance caregiving, sandwich generation carers, and caregiving related resignation. Along with an aging society, the government social protection budget is becoming tight. Also, the shortage of human resources caused by the decrease in working age population. Furthermore, there is a still social norm that the care is each family's responsibility, though Japan has been aiming for socialization of care. Under these circumstances, caregivers' tasks will increase. Too much care burden might lead abuse. Under an accelerating aging society, we are facing the risk of setback in dementia care and an increase in carers' roles. Now, we must advocate for the personhood of both people living with dementia and carers. Tomoki's person-centered care, there are 5 psychological needs: comfort, occupation, attachment, inclusion, and identity, which are essential for both. Now we have entered an unprecedented super-aged society. It is time to reaffirm the essential meaning of care. Care should never be one-sided. Both sides' well-being is essential. Care is not merely a task and burden, it is an essential activity of human beings. We have to respect both sides' personhood and must seek a compatible way. From birth to the end of life, human beings are cared for by someone and also take care of someone. Living in this unprecedented super-aged society, we need to aim for care-centered society. Some initiatives have started aiming for a care-centered society, such as local government ordinance to support caregivers, declaration by the stakeholders organization to advocate for caregivers' human rights, and enhancing the training program for caregivers, etc. So this is an example of a caregivers training program conducted by Alzheimer's Association Japan Aichi branch. Benefit carers better QOL. We have to try hard to forward an inclusive care-centered society. I would like to conclude my presentation. Japan started from the phase of denying the personhood of people living with dementia. Then we have accumulated the knowledge and experiences of error and trials. We achieved some degree of dementia care in the system and implemented the Basic Act. However, we are facing a critical challenge: how to realize a secure and comfortable super-aged society. I believe a care-centered society is the key. Aging is a global issue. I hope we learn and work together for the care-centered world. Thank you very much. Good morning, everyone. I'm Nodio Washizu, Alzheimer's Association Japan. Thank you for the great opportunity to join this excellent conference from Kyoto, Japan, 8,000 kilometers away. It is wonderful to share dementia care across borders and oceans. I will discuss the history of dementia policy and care in Japan and the challenges we are facing and strategies. First, I'd like to introduce the Japanese situation. Japan is one of the most aged countries in the world. The aging ratio is 30% now and will reach 40% by 2050. Demographic structure is entirely different from India at present, but aging is an urgent global issue. So I'm pleased if my presentation helped to prepare for the future. Along with the aging, the number of people living with dementia is 4.5 million and people with MCI is 6 million now. Next, this is the overview of Japan's history of policies for older people and dementia. We established basic social protection such as universal health insurance and universal pension in 1960s. The upper half in blue is the policy and initiatives for elderly as a whole. The lower half in pink is for dementia. The first government measure for dementia was in 1987. I divided this history into three parts and discuss. This is the phase 1 before 2000. In this period, dementia was named Chiho in Chinese character. It means stupid and insane and is a discriminatory name. Care was considered each family's obligation, and there were extremely limited social services and no medical treatment. Under these social circumstances, family carers hit people living with dementia as a family's shame. Their last resort was institutionalization, such as psychiatric or elderly hospitals, where restrictions, lifelong admission, and social exclusion happened. Left side photo is from Kazuo Okuma's book, the report of elderly hospitals. He is a renowned journalist in Japan. The right side is Dr. Hayakawa's word when he visited his patient. He is one of the founders of Alzheimer's Association Japan. His word, I found patients with dementia who were locked in horrible compartments in their houses. I felt deep sorrow and pain for both patients and their families. Let's move on to the second phase from 2000 to 2023. This is the period of development in dementia care in Japan, and many initiatives are implemented in the public and private sectors. Around 2000, person-centered care was introduced to Japan. It had a significant impact on dementia care. At the same time, the long-term care insurance law was implemented in 2000, and it declared advocacy for people living with dementia. Also, the national dementia plans were implemented. Training programs based on the person-centered care theory are promoted. And the Dementia Supporter Campaign, known as Dementia Fund globally, started. The number of supporters has reached 14 million in this year. In 2005, Japan changed the name for dementia from derogatory word to descriptive one. It greatly contributed to reducing the stigma and changing the social perception of dementia. Also, people living with dementia started to speak out to society through their own voices. Their voices have been driving forward to dispel misconceptions about dementia. Such accumulated steps came to fruition in the establishment of Dementia Basic Law in 2023. Among institutions in the period, initiatives in this period, I will add a brief explanation about the long-term care insurance, the Dementia Basic Act, and introduce the ongoing achievement of people living with dementia. First, I will talk about the long-term care insurance implemented in 2000. The long-term care insurance system supports people in need of long-term care due to aging, among other factors. The purpose is to support people who need care themselves and not caregivers. But it has improved the quality of life of people living with dementia and also the care need and also their caregivers significantly. It has been successfully operated for 20 years. However, the problems start emerging. I will talk about them later. Next, the Dementia Basic Act. This act is the principle of all dementia policy and measures. National policy is essential for dementia issues because dementia is not only an issue of medical and care, but the entire lives, such as work, shopping, banking, transportation, etc. It relates to all aspects of life. Through our 40 years of experience, I would like to emphasize the importance of national policy. The goal of the Dementia Basic Act is inclusive society. There is a four key points. 1. Stakeholders participation. 2. Integrated approach. 3. The responsibility of government, service providers, and citizens. And 4. Governance by the Cabinet Office. Next, the current active movement of people living with dementia. Medical development has enabled early diagnosis, allowing people to take an active role with a supportive environment. Based on dementia basic law, both public and private sectors are responsible for supporting it, and their voices have grown increasingly powerful over time. Of course, we are still at the starting point of inclusive society. Even so, it may be said that we have developed dementia care to a certain level, but at the same time, we are facing the following serious challenges. Let's move on to the phase 3. Further and rapid aging impact all aspects of society and of course on dementia care. Example of impact are living alone or every couple household, older carers, long distance caregiving, sandwich generation carers, and caregiving related resignation. Along with an aging society, the government social protection budget is becoming tight. Also, the shortage of human resources caused by the decrease in working age population. Furthermore, there is a still social norm that the care is each family's responsibility, though Japan has been aiming for socialization of care. Under these circumstances, caregivers' tasks will increase. Too much care burden might lead abuse. Under an accelerating aging society, we are facing the risk of setback in dementia care and an increase in carers' roles. Now, we must advocate for the personhood of both people living with dementia and carers. Tom Kitz's person-centered care, there are 5 psychological needs: comfort, occupation, attachment, inclusion, and identity, which are essential for both. Now we have entered an unprecedented super-aged society. It is time to reaffirm the essential meaning of care. Care should never be one-sided. Both sides' well-being is essential. Care is not merely a task and burden, it is an essential activity of human beings. We have to respect both sides' personhood and must seek a compatible way. From birth to the end of life, human beings are cared for by someone and also take care of someone. Living in this unprecedented super-aged society, we need to aim for care-centered society. Some initiatives have started aiming for a care-centered society, such as local government ordinance to support caregivers, declaration by the stakeholders organization to advocate for caregivers' human rights, and enhancing the training program for caregivers, etc. So this is an example of a caregivers training program conducted by Alzheimer's Association Japan Aichi branch. It benefits carers better QOL. We have to try hard to hold an inclusive care-centered society. I would like to conclude my presentation. Japan started from the phase of denying the personhood of people living with dementia. Then we have accumulated the knowledge and experiences of error and trials. We achieved some degree of dementia care and system and implemented the basic act. However, we are facing a critical challenge: how to realize a secure and comfortable super-aged society. I believe a care-centered society is the key. Aging is a global issue. I hope we learn and work together for the care-centered world. Thank you very much. Good morning, everyone. I'm Nobio Washizu, Alzheimer's Association Japan. Thank you for the great opportunity to join this excellent conference from Kyoto, Japan, 8,000 kilometers away. It is wonderful to share dementia care across borders and oceans. I will discuss the history of dementia policy and care in Japan and the challenges we are facing and strategies. First, I'd like to introduce the Japanese situation. Japan is one of the most aged countries in the world. The aging ratio is 30% now and will reach 40% by 2050. Demographic structure is entirely different from India at present, but aging is an urgent global issue. So I'm pleased if my presentation helped to prepare for the future. Along with the aging, the number of people living with dementia is 4.5 million and people with MCI is 6 million now.
Welcome back, everyone. May I welcome the moderator of the session, Dr. Priya Raghavan ma'am, consultant geriatric psychiatry, Kadabam's Hospital, Bengaluru. Welcome, ma'am. The symposium is on the topic Dementia Inclusive Future. Where are we and what is awaited? May I now request our modulator to introduce the speaker to the gathering. Over to you, ma'am.
Good afternoon, everybody. We are starting the afternoon session now. So we've got 3 speakers lined up for our symposium. Dr. Radha Murthy needs no introduction, but as you can see from the slide, Madam is the president of the Dementia India Alliance and also of the Nightingale's Medical Trust, where she's the founder of the Home Health Services as well. She has won multiple awards, including the Nama Bengaluru Award, the Vayosreshta Samman Award, etc., in honor of her services to the elderly people. Today, she will be talking to us about dementia care model within the Nightingale Medical Trust. Secondly, we have our speaker who is based in Mysuru, Dr. Krishna KR, who runs his own fabulous elderly care service within Mysuru. He is a consultant psychiatrist currently associated with Kadabam Spark Hospital in Mysuru. He is going to be speaking to us today about dementia care model in Mysuru. Our third speaker is Dr. Pritesh Rohan Kiran, who is an associate professor at the Department of Community Health in St. John's Hospital, Bengaluru. As you can see, he has multiple publications to his credit. He is an expert in many different areas, including training, teaching, and he has won several accolades, including the Young Scientist Suvarna Karnataka Awards. So, can I first welcome Dr. Radha Murthy on stage today? Thank you. Hello.
Okay. You can put her presentation. Good afternoon to all of you. And at the outset, I would like to thank all the organizers of this conference. It's been a real pleasure to be here and to share my experiences. We heard a lot of dialogues about what is dementia, what is the other technology things, but I'm only talking about the care. Now, as a clinician, all of you would have noticed that when a patient comes and diagnosed with dementia, the family, along with it, whoever is there, what is their reaction? The first reaction is, oh, what does the next step? Where do I go? What am I supposed to do? Where is the support system? Many times they just come to their residential care and say, please, can you admit? Because he has dementia. Because they have not understood there are other support systems to keep the person at home. Many times a 90-year-old person, I go and counsel them even before I admit them. I tell them, why don't you look after her? 90 years she's been with you. What is that? No, she has incontinence. She doesn't listen. She screams. Sadly, what is that everybody is looking for is support systems. I think that's very crucial for dementia. So here I'll just few models which we have started looking at the needs of what type of support a person with dementia has. Now, I don't want to go back to how many millions are there because it's been spoken again and again about the whole thing. So I can just put it there. It's what 8.8 million, which I'm not going to elaborate on. 25 million Indians have probably lost their quality of lives because of this livelihood and financial stability. And 2 family caregivers are required for 1 person. Cost of dementia, I've always been saying that it's really, really hard. And to find an affordable solution to this has become very, very difficult. Healthcare, what is it? Am I doing the wrong way? Yeah, right or not? Yeah. And again, it's not a health priority, has already been mentioned. Now, what are the challenges? I think most of you know what are the challenges. One is lack of awareness and stigma. Yes, people are still not aware whether it is normal aging or dementia. So that is a thing. And they don't seek for help because they've already understood that it's just aging. Specialists, yes, dearth of specialists, and people do not know whether to go to a neurologist or a psychiatrist. Still, psychiatrists and neurologists are very limited. Lack of trained professionals, yes. Caregivers are there, they are trained in geriatric care, but still, when they go home, they do not know how to look after patients with dementia. Accessibility and affordability is a big, big question, is because you know the cost of care. So I don't have to say that because they have already been mentioned. It's a very difficult. And the services available of daycare, though I have not put the numbers because it was a long back, memory clinic and residential care are very, very limited. So this leaves a lot of numbers of people who will not be able to access any of the what do you call as problems. Now, what could be the ideal situation? How should it be? Memory clinic for diagnosis. That's the first step which anybody could have done. As it progresses, what do you need? A support group and counseling. As it further progresses, you need definitely a daycare and a training. This is the ideal situation. And definitely the institutional care, because in the end of the thing, you may not be able to look after them at home. So this is the institutional care is also a must. Now, this is our what we are doing at Nightingale. If you look at it, we have memory clinics, DEM clinic online. That is, we assess them online, and that is through Dementia India Alliance, what we are doing. And in person, people just walk in. We have residential care in 4 locations. Daycare, we have 4 locations and home engagement. Residential care, there are 3 of them which I mentioned. Nightingale Center for Aging and Alzheimer's, a 100-bedded facility. Teledementia, which is at Kolar, 50 people are there. And Nightingale Trust for only women, there are about 24 people there. And the support is active aging training and support group and counseling. Now, when I come to the residential care, dementia care, let me talk about residential care first. What is that said, which I mentioned already, 100-bedded facility. Now, why did we think about this? Now, we need a comprehensive care for anybody because once a patient is the same, when they come to the center, we cannot say go there and go here and, as it is, they are perplexed about how to take care. So a comprehensive center of residential care is a very must. A memory clinic, we have a daycare for dementia in that same area, in the same place, and short-term, long-term respite care. And we have definitely all psychiatrists, psychologists, and all of them there. And plus, we have professional caregivers. The second one, which I was telling you, it's in Kolar, which is a telemedicine enabled center. Here, The hub is at Kasturi Nagar, that is at the local place where is the 100-bedded facility. From there, we are looking after. The cost comes down considerably, about nearly about 40% of cost comes down. So it's easier for the people who cannot afford to come to this setting. Again, it's located in a hospital, which is very useful to us, is because of the closeness of medical help. Having this, it makes it's same thing, same. The quality remains the same. The quality of care remains the same, whether it's a technology enabled or if it's a regular one. This is only for the women, which we were thinking, because sometimes they did not want, so many of them did not want to be in the same section. So this, again, the same services are there, the memory clinic, short-term respite care. Now let me talk about the dementia day care, which is a very useful care service. And it's doing so well is because this respite. Many of them do not want to go into the residential care. They have that feeling of guilt, the stigma to be putting there. And the person is also in a stage where the person can get into these activities. So we have this, and well-planned schedule is there. We look after about nearly 50. The Jayanagar Center literally caters to 50 people. I don't know how it is, but in the south, the thing is that numbers are quite a lot. But when you come to the north side, it's a little lesser. I don't know what is the reason, but here on the north side, probably the awareness is better. So this is the thing. Now let me go to active aging. How do you do this? Why do you need active aging? To reduce the risk of dementia. You all know hypertension. I don't have to tell you all of this thing. Hypertension, your diabetes, your lifestyle has to be changed. How do you do this? So to get the risk reduction, we have a model of online screening, because before COVID, they used to come there over to the place. But after COVID, we learned that we could do the care online. So this was the thing. You all can read it. Using household items itself, you can do the weights. Involvement of grandkids, because they are the ones who are going to connect you to the Zoom. They're going to sit with you and they explain. So that also happens. Mobile active aging. When you say mobile active aging, it is for, we had wondered, like many of you have seen the old age homes. I don't know how many of you have seen the old age homes. Many of them have these problems of dementia, but they're not able to understand how to take care of them or anything. So we thought about how do we reach them. So this mobile active aging model we have taken, we go to old age homes, about 2 in a day, in a week about 6 old age homes are covered, wherein exercises, small exercises, chair-based exercises, because you know very well that they are not capable of doing high-end exercises. So these are the ones which. And the last one I wanted to tell you is the program is free of cost. And we have learned a lot from that particular thing. We have learned a lot from here. How do we look after care? I mean, especially in the old age homes. We've done a lot of survey and we found that many of them have dementia which is not recognized. And this active aging has helped a lot in these times. Any hand raising? Okay. Training. Now we have training is another aspect which you have taken up, is because one of the things is in-house also we have to train them because there are not enough specialized home care people. I still want to say that home care is one of the things which we really have to promote. It's very difficult, but I think one of the most important things in a community is home care. Anything is, and I always tell them whenever they come to residential care, I try to ask them, why don't you give them at home? Can we support you by training your caregiver? Because I feel a person is quite comfortable at home till the last. I mean, he could be still looked after. Somehow, many of them try to, I do not know, maybe out of need or wanting to dump because they find it comfortable that the person, somebody is taking care and they're comfortable. So these are the things which are things. So we have to promote home care, and I feel how to support families in their own homes. So if we do the training in their homes, I think that would be one of the best models which we could take back. Now, training, when it comes to training, we do different trainings. Once we do the dementia, sometimes training, it was also through the DIA, we do that. Training in bedside assistance for the youth. Computer skills, smartphone, and digital payments for elders is through another program of ours, which is not associated with this, but this does help the elders to take care. This is called, we call it the Job 60 Plus, wherein we train all the elderly for the soft skills and smartphone. Skills training for elders and post-retirement placement also. These are the things which we do. Awareness and advocacy is one of the most important things, because as I told you, there still people are not aware of what Bangalore is there, but the awareness is very high. I'm not saying that, but there are many people who come from other states to our place. Awareness is very, very poor. So we are very keen on awareness, and we do quite a lot through Dementia India Alliance. And we observe the World Allergy Day, International Day conferences and workshops. And conferences are one of the things which really, really help to spread and make this awareness and get over the stigma. Smriti Gram, this is our dream, our future dream is to have a place wherein here it's a restricted place. In Bangalore, we have a very restricted place. It's not enough a person have a homely atmosphere. So what is the answer? So we bought a 5-acre land. What we were, it will be a 300 bedded facility, but the first 100 will be a free one. So it's already in construction. The training hall is already ready. A training hall which is fully equipped for training. And this 100 bedded will be for people who cannot afford. It will be a free service. And we hope that, I think by the year end or something like that, at least by next year, I think next year, within about June or July, we'll be able to open. So this is one of the things where this is our future dream of how to take care of people. It should be well equipped. So these are the certain therapies, what all is going to be there. You could go through that. Large dementia-friendly bathrooms, amphitheater, sensory garden, safe wandering. So these are the things which we have already envisaged. So with this models of care, which I said, I just put it in brief. A comprehensive care is very, very essential for everybody. The more the support systems are there, the better it is. Though I wouldn't say that residential care is very, very necessary, because we should not be promoting it, but still, there is a lot of people who still need residential care. So wherever there is a need for a support or something, we will be definitely there to help you all out. So thank you with this for this lovely. Anything to be?
Yeah. Next, yes. We have Dr. Krishna. For each speaker, we are giving 15 minutes. So we can have discussion at the end. Thank you, Dr. Krishna.
Much. Radha Murthy. She gave an impressive talk about residential care facilities. But today I'm going to talk about what is the model in Mysuru, what we have got, and how it is working. Because our problem is here is totally different than, somewhat different. It's not the same, but it's somewhat different than from the Bangalore. So, and why we want this model to be. I think, next slide, please. Hello? Okay. Sorry about this. So let me put another next slide, please. So next slide. No. So we have put that dementia care model, which is the Mysore model, what we have. And oh, this one, I can work from this, isn't it? Oh, okay, okay. All right. I didn't know. So just my introduction myself, I'm a consultant psychiatrist at Manipal Hospital. Revive Hospital is our hospital, and the new hospital which is coming up is Kadavam's Spark. I think she is also part of the hospital. So the next slide. So we wanted one model which is very cheap. We can do that in Mysore, and because of the dynamicity of the patient load here, and accessible to almost all. It may not be like impressive like what Dr. Radha Murthy's care model is, but ours is little bit step down version of those. But I think we can go with the care what we can provide with the same amount of care with the because we here I come from both background. I worked in UK as well as in India, so I know what was there. They had a lot of money to spill around. So the model was very great. Everything was taken care of. Once the patient comes to the OPD, from there, or GP will diagnose itself, and he will send to the geriatric team, and there everything will be taken care. But that doesn't happen here. Here we have a lot of problems for it. And that too in a city like Mysore with the varying population, it's quite difficult. So this model we evolved through using nice IPS guidelines as well. Indian Psychiatry, not IPS guidelines, IPS newsletters, and it's a consensus based. And I discussed with Dr. Shilpa Auravel. She's also a geriatrician, and we came through this model. And I hope everyone understands, and I think this can help some of the budding doctors and the specialists who can go through that, and they can find where to send to the patient, whom to send to, as well as get a clear model where the patient has to go. Next slide. As Dr. Radha Murthy had said, in India, in Mysore, literacy is very poor in certain areas. And there is a difficulty in language as well. Why I'm saying that is because when you're assessing the patient, it becomes very, very difficult to assess the patient whether they have dementia or not, because some of that dialect even I can't understand, and you need certain people to understand what they are talking about and things. Dialect is different, socioeconomic state is also different, and urban versus poor. Previously when MMSC came to India, I think 15 MMSC, I think it's one of the tests we do to diagnose dementia. We had a certain dementia MMSC for very socioeconomic as well as for the uneducated, but now we don't have that one. So there the problem is we can't use that at this point in time. So how to diagnose the patient who is illiterate? How do you do that one? It becomes very difficult. Then also the question is, if the patient has memory problem, whom to approach? Madam has said, whom to approach? Is it a psychiatrist? They don't know psychiatrist at all. They don't know neurologist. They don't know anything. What they go is they just go to a GP. GP will say, okay, I think memory loss, old age. Why you have to bring that here? Yeah, he will die in next 5-10 years. So it's fine. That's what their approach is. So that becomes a real problem. Okay. So, but there is also a problem from our side as well. Most of the profession now, there are more number of psychiatrists here, around 30 psychiatrists are there in Mysore. But if believe me, most of them have very poor knowledge, even with regard to dementia treatment and how they go about that. And very hesitancy is there. This is not only with us, even with neurologists. I have seen how they prescribe is totally different. And it doesn't help any of the dementia patient at all. That's the problem. Next is no proper guidelines. We don't have a proper. There is a nice guidelines in UK, but that guidelines we can apply, but it is so cumbersome. The same guidelines can't be applied to India. And Indian guidelines is there. This one, it's a 15-20 pages there from the Niman's team had done. But most of them, if you read about that, you will not able to know how to apply that. That becomes a problem. And paucity of other healthcare providers that we all know. We don't have any other. You are the soul and whole and soul. You have to deal with the patient. Once patient comes to you, you have to know where to send, which to send, and how to treat that patient. So these are all problems we have. So even if I don't blame any doctors, but once the most of our doctors, psychiatrists, or for the neurologist, when they become very busy, will have only 4-5 minutes to spend the time. They can't do MMSC with the patient. They can't do any of that. So they just treat that. They don't give any education to the family. What next will happen? What are the pathways? Nobody will tell. So the problem is there. It itself is the problem. Okay. So we came up with a simple model, and I hope that will help. Which includes everything, and we want family as the main part, not as the family is the one who will cater here. Most of them don't want to send to the nursing home or treated in the inpatient unit. So what they want is most of the patient to be treated at the community level or at their own home. So simple stepped care approach. It's a structured model. It should be, and it should be need based. Whenever they want, we will provide the help. That's all. It's and also right based, whatever we can put. Least restrictive model. We should not use any of the restriction. Better to avoid nursing home. That's the model. Okay. So risk reduction and prevention is the main goal. So what our model was, we came with the consensus. We have been working like this since last 5 years. Within if the patient comes in the OPD, within 3 OPD settings, they will after 3 they will not come back at all. So within 3 OPD settings only, you have to give as much information as much as possible. If you don't do that, the patient will not come back. The patient will not be understanding what is going to happen, what is the pathways are. So nobody will understand. So within 3 OPD sessions, you have to tell the patients, this is not patient's family, that this is going to happen, and the pathway is like this. They will deteriorate. Whatever you are going to give information, and how many years it will deteriorate. You have to treat as well. You have to do a lot of things. So you have to spend more time with patients and family. So this is the OPD model. First, and the second, if that doesn't work, the stepped care model. You go to the family and treat, or you have a liaison with the nurse and start treating. But here also, its a main approach is family itself should take care of the patient rather than to be at the nursing home or 15 minutes over. Sorry. The third is inpatient care model. Fourth is preventive care model. Sorry. So as I said, when the first instant when the patient comes to you, you have to use whatever your knowledge is. And one thing I have to tell all the doctors here: learn MMSC by heart. You can use within 5 minutes. And once within 5 minutes, if you can use it, you can treat the patient. You can do all sort of things with it. So all the doctors here has to learn MMSC. That's the main thing here. If you know MMSC within 5 minutes, you can treat the patient and you can send, and subsequently you can do as a rapport with the family, and where you are heading. So while they come here, you have to find what is depression. Is there a depression, delirium, and other health issues, so that you need to treat properly whether it's dementia or not. So decide in the first instance only, you decide whether it should be an OPD based or step care or admission, but it should be should be OPD based. So comprehensive history take more time, half an hour to 1 hour. More, I would say 1 hour is sufficient time for the first visit, and later on you can take half an hour and move on. So in that time you should know MMSC. Yes, ASR is not required. ASR Kannada version is there. That's easier one. But your psychologist, if you have this one, you can use that. and functional tone, these are not required at this point. So routine investigation, all investigation needs to be done in the first instant only. When the second time they come back, you should have all the investigation. In India, we better use vitamin B12 and D3 also should be there along with MRI brain scan, but not CT scan. It's okay, but MRI brain is the preferable. Then see, in the first instant only, give all the feedback, education, everything needs to be given in the first instant only. In the second instant, it should be easy for you. Once you're given all the information, you just need to check around and review the patient and whatever where the patient has to go, all that. So the medical management, I think most of them would be knowing. As much as possible in the first instance, if you know that's a dementia and you are going ahead with that, better to start treating at that time. Because most of in Indian patient is, if you don't prescribe, they will say that you have come with this problem, you are not prescribing. Unless the investigation is not done, don't wait for the investigation, just treat. Start treating in the first instance. And then go back. Then you treat the BPSD, behavioral and psychological symptoms of dementia. First is approach non-pharmacology. These are all for the doctors who are bedding doctors. Then psychotherapy is caregiver. These are all. So another thing which I was talking about is a stepped up approach. All these patients who, if you feel that they requires treatment at home, go to the home, and you will find a lot of environmental, what are the problems they are facing, and you can easily give feedback to them. As a doctor, we can all do that one, and that's what part of that. That reduces the amount of money the patient spends or the family spends on the patient. That's the main idea is as much as possible, it should be a cheap model, and at the end they might go into residential care. Yeah, but as much as you push around, that's the best. They stay with the families and treat them. So as I said, the goal is to keep them in the home as much as possible, with or without support from the carers. So next, and you should have a clear admission criteria. But here, over 20 minutes. Okay. Okay, just there's no admission criteria here, but I have written that. But as you know, anyone, as Dr. Radha Murthy had told, anyone if they want some support, they want admission, they will come. So there is nothing as such. So de-escalation, all these things, these are more for academics. What needs to be given support and community, it's better to link with all the doctors. Psychiatrist has to go and link with all the doctors or the neurologist, and more telepsychiatry follow-up would be much better. Yearly assessment, and the main thing is the treatment, or prevention. What are the needs to be done, and these are the things. Okay, I think this is the end of that. Again, going back, what is the model is 4 set of models. Where is it? Sorry. OPD care model, stepped care model, inpatient care model, and a preventive care model. This is mainly for the doctors, private psychiatrists, or the neurologist who are working in the outpatient setup. Even for the hospital also, this can be applied. And you can step up as much as you possible. Okay. All right. Thank you very much. Sorry, I have to rush on.
Thank you very much, Dr. Krishna. Next, we have Dr. Pritesh Kiran, who will do his presentation. After this, we'll have a brief discussion.
Good afternoon, everyone. And I think it's a very difficult task, since it's post-lunch. And I did hear somebody snore some time ago. I thought I did hear it right. In spite of which, some people are not waking up. But anyway, it's quite a tough task. The system was story. Okay. Right. So at the outset, I'd like to thank the organizers of this conference for having invited us to be part of this, important conference. And today I'll be actually talking to you all about the importance of inclusivity as far as dementia care is concerned, and where exactly are we in terms of a nation, in terms of policy towards dementia inclusivity. So just have a look at this video just to wake you all up, and we can then reflect.
ಎಷ್ಟೇ ಹುಡುಕಿದ್ರು ಒಂದ್ ಸೀರಿಯಸ್ ಫೋಟೋ ಕೂಡ ಸಿಗ್ಲಿಲ್ಲ. ಯಾವಾಗ್ಲೂ ನಗ್ನಗ್ತಾ ಖುಷಿಯಾಗಿರ್ತಿದ್ರು. ನಮ್ ಸಂಸ್ಥೆನಲ್ಲಿರೋ ಎಲ್ಲಾ ಹೆಂಗಸರಿಗೂ ನಿಮ್ ತಂದೆ ಕಂಡ್ರೆ ಒಂದ್ ಹಳೆ ಕಾಲದ ಹೀರೋ ಫೀಲ್.
ಅಮ್ಮ ಬರಲ್ವಾ? ಅಮ್ಮ ಬದುಕಿದ್ರೆ ಇವಾಗ ನಮ್ ಜೊತೆ ಇರ್ತಿರ್ಲಿಲ್ಲ. ಏನಾಗಿದೆ ನಿಮ್ಗೆ?
ಲಾಸ್ಟ್ 4 months ಇಂದ ನಿಮ್ ತಂದೆ ಕಂಡೀಷನ್ ಇನ್ನು ಜಾಸ್ತಿ ಸೀರಿಯಸ್ ಆಗಿದೆ. ಹೊಸದೇನು ಜ್ಞಾಪಕಕ್ಕೆ ಇಟ್ಕೊಳಕ್ಕಾಗಲ್ಲ. ಹಳೆ ನೆನಪುಗಳಲ್ಲೇ ಕಳ್ದೋಗಿರ್ತಾರೆ.
ನಾನು ಹೋಗದೆ ಇದ್ದಿದ್ದು ಒಂದೇ ಒಂದು ಜಾಗ ಇದೆ ಅಂತ. ಯಾವ್ದು ಗೊತ್ತಾ?
ವೆಂಕೋಬ್ರಾವ್ ಎಂಬ 66 ವರ್ಷದ ವ್ಯಕ್ತಿ ಬೆಂಗಳೂರಿನ ಬಸವನಗುಡಿಯಿಂದ ಕಾಣೆಯಾಗಿದ್ದಾರೆ.
ಮಿಸ್ಸಿಂಗ್ ಪರ್ಸನ್ ಕಂಪ್ಲೇಂಟ್ ಫೈಲ್ ಮಾಡಬೇಕಾಗಿತ್ತು. ಮಾನಸಿಕ ಸ್ಥಿತಿ ಸರಿ ಇಲ್ಲ ಅಂತೀರಾ, ಸರಿಯಾಗಿ ನೋಡ್ಕೊಳಕ್ಕಾಗಲ್ವಾ? ಇಲ್ಲೆಷ್ಟು ಜನ ಇದ್ದಾರೆ ಅಂದ್ರೆ ಒಂದು ಮನುಷ್ಯನ ಜೀವಕ್ಕೆ ಬೆಲೆನೇ ಇಲ್ಲ. ನಮ್ ಪ್ರಯತ್ನ ನಾವು ಮಾಡ್ತೀವಿ, ನೀವು ಹುಡುಕೋದನ್ನ ನಿಲ್ಸ್ಬೇಡಿ.
ನಾವೊಂದ್ ಕಡೆ ಪ್ಲಾನ್ ಪ್ರಕಾರ ಈ ಬ್ಯಾಡ್ರಿಗೂ ನಮಗೂ
ಯಾವುದೇ ಕಾರಣಕ್ಕೂ ಹೆಚ್ಚು ಕಮ್ಮಿ ಇಲ್ಲ. ನಮ್ ತಂದೆ ಹುಡುಕಾಡ ಪ್ರಯತ್ನ ಇದೆ. ನಾಯಿ ಇನ್ನೊಂದು ಬಿಳಿ ನಾಯಿಗಳು ಒಳಗೆ ನಾಯಿಗಳಲ್ಲಿ ಗೆಲ್ಲೋದು ಯಾವುದು?
So this is a clipping from a movie called Godi Banna Sadharna Maikattu. I'm almost around 10 years old. And at that point in time itself, you can look at the realities of dementia as well as the issues faced by different individuals, patients as well as their families. So it's a very important aspect that we need to look at the way in which different people, different constituencies are actually sensitized to the fact of dementia, and how exactly they need to deal not only with people with dementia but also their caregivers and extended families. So these are just some recent clippings. You can see how the police as such actually helped one particular patient with dementia and helped him to be able to get him back home, as well as the fact that in Calcutta, this is 2019, right? The police again had some amount of an involvement. You saw in that clipping how the police actually behaved, right? The policeman said, your father actually has a mental illness, can't you look after him properly, right? When he's already facing such a lot of stress and additional stress of guilt being actually given out, right? So it's very important that we need to actually gear up for this increasing epidemic of dementia across India and across the world. So if you look at numbers, I'm not going too much into this. We've already know that we have close to around 57 million people with dementia in 2019 as far as globally is concerned, and it's projected to rise to 150 plus million by 2050. What is very important is the set of risk factors which are also on the rise, right? So we have multiple risk factors that you would have actually come across in terms of increasing the chances of dementia. And the Lancet Commission actually in its article has outlined 14 different risk factors. Many of them non-communicable diseases, right? Things like diabetes, hypertension, hearing impairment. So many things which are prevalent, which are not picked up. Former speaker mentioned about how it is very important to be able to ensure that there is a comprehensive geriatric assessment that is done, right? It's not sufficient just for an MMSC to be done. It is important for us as a physician, as doctors in the making, when a patient comes to you, do a complete assessment of that individual. Do not stick only to one particular aspect, right? So when we say complete assessment, you need to look at the social aspects of the person. You need to look at familial support, financial support, functionality, right? ADLs. Is that person able to do certain things on his own? Is he dependent? Risk of falls. So multiple such components need to be looked at in a short span of time, but in an effective fashion for you to be able to pick up any of these risk factors which are there, which can be, very important for dementia, right? There are many other social aspects, poverty, income inequity, as well as, certain pandemics like, HIV, which can also, have an impact on dementia. So as of 2025 May, only 45 member states of the WHO had actually been a signatory to the National Dementia Plan. This morning, actually, Ramani, mentioned in her talk. And in fact, India is not necessarily, one of them who is already, having a plan in place, right? Now, the Indian scenario as such is also no different. We have a large number of, people living with dementia, and by 2050 as such, that number is expected to be approximately around 340 million older persons living with dementia, right? The dementia policy as such, even though there is evidence that the burden of dementia is so much, has not fully evolved. Quite encouraging that Dementia India Alliance recently, around 2 months ago, was in Delhi to be able to look at evolving such a policy and trying to ensure that the rights of people with dementia and their caregivers is protected. Also, there are a lot of inequities in terms of poor awareness, in terms of lack of professionals, as well as a lack of public health prioritization. If you actually go across to any of our primary healthcare centers, dementia or care of the elderly is not on top of their bucket list. If somebody actually comes saying, I've got Kaikal, no, they will just give you a prescription with paracetamol or diclofenac or aceclofenac, or if it's a little bit more serious, then maybe tramadol, and send you away, right? So it's important for us to be able to look at ways in which we can sensitize professionals and ensure that prioritization is given, especially to an aspect such as dementia, which is taken as a nature of usual common problem as far as aging is concerned. Next slide, please. It's not working. Right. Yeah. So there are various challenges as far as the rural context is concerned. We have close to around 65% of our population who is actually located in rural areas. And many of the younger people in rural areas are migrating out of rural areas in search of employment, which means to say that older people are actually left behind there as far as individuals are concerned. And caregivers as such are a challenge. Even if there are caregivers who actually stay back, they have to lose their employment as such. They have a huge amount of burden physically, mentally, socially, and financially. Next slide, please. So multiple other issues in terms of understanding, in terms of social isolation, in terms of the resources for continuity of care. A few days ago, we were discussing with colleagues, from the dementia clinics, saying that what happens in community surveys or community screening. So people get screened and picked up positive, for cognitive decline in the community, but none of them then come back, for a follow-up or for further evaluation. Reason being the costs, reason being, the kind of burden in terms of coming back, and going through multiple, tests. So there is a lack of, resource. There is a lack of, facilities in terms of distribution, as well as, a lack of physical environment, especially in rural areas, right? So especially in rural areas, when you actually, or even in the urban slums, if you actually see the houses, many of them are one-room houses or two-room houses, where recently one of my postgraduates actually presenting a family study where he said there are 6 members staying in a 20 feet by 20 feet room. 6 members. Can you imagine, right? So that is the kind of challenge that we have as far as rural and urban underprivileged areas are concerned. Next slide, please. There is also a lack of caregivers who are actually trained, right? It's very important for us to focus on caregiver training. Dr. Radha, my colleague, mentioned about the fact that the Nightingales, as well as Dementia India Alliance is focused very much on caregiver training, and that is something very important, because caregivers very often do not know what to do. They are not necessarily included as far as the entire treatment plan is concerned, right? Many a times it's largely, medications being given and the patient being sent back. Next slide, please. So at St. John's, we actually have developed a model of, healthcare for the elderly. And as part of that, we also have care of, people with cognitive decline. So this started in 2002, 2003. It started in the Department of Community Health with the community-based, model. So we have almost around 30,000 underserved individuals who are reached out to every year, right? 30,000 patient visits, in the community, in old age homes, in various different settings. And very recently, in 2024, last year, we started the St. John's Geriatric Center, right? So it's a 150-bedded center on the campus of St. John's. And that provides actually short-term daycare as well as long-term care, as well as hospice services under one roof. Next slide, please. So like I told you, there are hospital-based services, community-based services. Next slide. The hospital-based services at the St. John's Geriatric Center. So there are outpatient services, inpatient services. There's a support to the outreach service. There is a component of community engagement. There's a component of training, as well as a component of research, which is also fit into as far as this model is concerned. Next slide, please. So this is some snapshots of the St. John's Geriatric Center. Right, it's a 6-storied building, with 150 beds. Right, almost 17,000 square feet on each floor. Next slide, please. So the community-based services are the following. Next. So it's run by the Department of Community Health. It's called the Senior Citizen Health Service. We have rural and urban geriatric clinics. There's what's called a home health service, where we have around 150 elderly whom we support on the home front when they can't come to the hospital. An institutional support service, around 6 old age homes that we are actually supporting. And lastly, the Grama Hiriyara Kendra model, which is a community-based model for psychosocial support for the elderly. Next slide. Capacity building exercises are conducted for various functionaries, various people. Next slide. So community-based services, you can see some snippets of the rural geriatric clinics, the old age home clinics, urban geriatric clinic in an urban underprivileged area, the home health service. Next slide. What we usually do, there is a health education that is conducted before each clinic. There's a clinical examination then by the doctor. There is a comprehensive geriatric assessment that we actually undertake, and we don't necessarily use the entire battery of tests for initial assessment, right? So we ask simple questions like, do you feel that the patient is more forgetful nowadays? Do you feel that the patient is a little bit more low or sad or disinterested nowadays? Does the patient have problems of insomnia? So caregivers who actually come across with the patient are also quizzed about some of these symptoms, and in a very surrogate fashion as such, we try and look at the deeper evaluations the next time around when the patient comes in. Drugs are dispensed at subsidized rates. There's also home visits by community level health workers from the community who've been appointed by us between clinics to be able to see if patients are doing fine, whether they require referral further or not. Next slide. We have counseling services by our medical social work team, both in the clinics as well as there are home visits by social workers. Next slide. Self-help groups have been created. So we have elderly self-help groups also who have been actually brought together. So there are certain finance schemes which are there. There are certain other programs which they actually undertake as far as the self-help and support groups are concerned. Next slide. Right, so the Grama Hiriyara Kendra model is like an Anganwadi for children. So like the Anganwadi for children, we started this model sometime in 2015, and we have elderly people coming in the morning to these centers. They say a prayer, they actually do some exercises, they do some yoga, they play some games, talk to each other, and then they leave. Next slide, please. So these are some pictures of the Kendra, what they do. They are singing some bhajans, playing local games, chauka, the chauka, whatever, that game as such. You can see some of the exercises, that these people do, right? In fact, if you actually see some of these people performing exercises at the age of 70 or 80, they put people, like me who are 40 plus, at shame, right? So the kind of flexibility, the kind of, mobility that they have after they have started doing this, they have realized the difference, right? So it requires some amount of motivation, some amount of making them understand why it is important. And what has it resulted in is a lot of people have have given reports of decreased sadness, of being more cooperative at home, of walking longer distances. Earlier 200 meters, now 2 kilometers. So all of these changes have been seen as far as these older people are concerned. Next slide. So there are various activity centers now in Maharashtra, in Telangana, in North Karnataka, right? So similar activities in these places. Next. Right, awareness sessions in that place, intergenerational bonding between school children as well as between the older people. Right, next. Right, and CMC Vellore in fact has a similar model, except that their focus is largely on nutrition. Next slide. Himachal Pradesh also has developed a state-based model on the same lines. Now what is very encouraging is that in Karnataka currently, the Rural Development Panchayati Raj Department has now adopted a similar model, right? To be conducted from the digital libraries. They are called the Arivu Kendras, the digital libraries, which are there in the Gram Panchayat headquarters. And as already 4 districts, almost close to around 100 centers have been opened up on a pilot basis, right? What is very encouraging also is, recently the government of Karnataka has linked up with Dementia India Alliance and announced that dementia screening as well as activities to promote awareness regarding dementia would also be conducted from these centers, right? So there's a lot moving towards prevention of dementia, towards ensuring social engagement as well as mental wellness. So many other examples from Karnataka. 2023, the Karnataka Brain Health Initiative we have actually heard of. We actually have centers in Bangalore South, Kolar and Chikbalapur, involving training. Also a dementia registry has been established. So Karnataka is actually the first state in India to be actually developing a dementia registry as such, right? Next slide. The Nimans Santwana neuropalliative care unit, the Nightingales Dementia Care Center, Manipal's COG works, Dementia India Alliance's national support helpline, as well as the Center for Brain Research in IASC, which is conducting a lot of research. So these are other models which are trying to actually bring out answers to different issues faced by people with dementia. Next slide. Yeah.
All right. It's not raining. Good. What? I've forgotten. Should I? I put. Oh, sit down. Yeah. Right. Oh, that way. I don't know what. Oh, I don't know. Oh, would you? I. Oh, I just. I do. I don't know. Chicken cheese. What? Chicken cheese? Sorry, oh, oh, I,
People with dementia have experiences like this every day. A little bit of understanding, tolerance, and patience can make all the difference.
Tell you what, if you go into the seats just there, right, when we get there.
Let me help you. It's this way. Thank you. Can I look at this?
Yes.
Chicken and cheese.
Oh,
Let's go this way.
thank you. Find out how to become dementia friendly. Contact Alzheimer's Society today.
Right. So from this, actually we realize the importance of different stakeholders, that are required as far as dementia care is concerned, in terms of, making societies dementia friendly and including, people as far as, society is concerned, right? So what is important is this stigmatization that is, there, that should not, be faced by people with dementia or their families, right? So who needs to be trained? There are various stakeholders. It is not just, the neurologist, the psychiatrist, or, this morning we were talking about which department, should be the focus department. It is a multi-stakeholder activity in terms of managing people who are, elderly, who are, with dementia, with, multiple such, cognitive decline. So medical students, different, medical students, MBBS, MD, your super specialists, nurses, allied health professionals, medical, psychologists, medico-social workers, hospital personnel. But this doesn't end here. Apart from that, training of, policy makers, of, students, school as well as college children, postgraduates, police personnel, cabs and bus drivers, flight attendants, bankers, supermarket workers, and the list goes on and on, right? What is important is to be able to increase that advocacy and awareness so that people are sensitized to this, increasing pandemic of cognitive decline as well as dementia. So do we need, dementia friendly communities? Yes. The answer is, it is important to be able to ensure that people, with this kind of an issue also have a dignified and a respectful, life as far as, the community is, concerned, for which the early recognition and management of, dementia, as well as, prevention of dementia through active aging, promotion, active aging programs is, key, right? So the way forward is definitely a coordinated action, right? It's not just one single bit. We need to look at, expanding prevention frameworks. You need to look at different ways by which different sectors can be involved, right? We need to look at, culturally appropriate interventions. Many a times, what we look at the West is possible there because, they don't have that much of a financial burden. But almost, close to around 80% of our population may not be able to, afford the kind of services which are provided by high-end homes or high-end centers, which is a burden on their continuing care for people with dementia. Meaningful involvement of affected individuals as well as their families, and developing a national policy towards this, right? So we need to look at socioeconomic determinants along with clinical care. That's very important. Very often, as doctors, we are taught to write a prescription, but not go beyond that. We need to be sensitive about what we write, the cost of which what we are writing, what are the options or alternatives that are available which are cost effective to patients. So all of these need to be looked at, especially in low and middle income countries, including our country as a whole. So thank you very much for a patient hearing, and look forward to interacting with you all further.
Thank you, Dr. Pritesh, for that enlightening presentation. I am told that we are actually running short of time and we may not be able to take questions. So I just wanted to say, does anyone have less than 1 minute comment? One person, if they want to make, that's fine. Anyone? Yes, ma'am.
I think the three speakers have brilliantly who have put their heart and soul into this. They have this passion, and the passion has continued, and they just did it out of vocation. So passion and vocation has brought out the best in whatever way. And Dr. Radhamurthy has led the way in dementia, which I remember way back how she started and how it all. And I think we need to give all the three speakers a big hand, because at the end they have gone into community. So we always sit with a prescription, but they have taken us to the community, and that is the need of the hour. There are a lot of questions. There's no time.
Thank you, ma'am. So I can expect that this will have probably generated a lot of discussion, but because we are running a bit short of time, I just thought I'll make a very quick few points, if that's okay with you. So I think thank you to all the three speakers. Fantastic talk, very innovative ways of maybe caring for dementia, be it through the online Zoom conversations, looking at active aging. I think those are all very good, simple ideas to implement and easy for communities also to get involved. We don't need major policies for that. And at a local level, Dr. Krishna has spoken to us about what might actually work here and given us an idea of what might not work. So thank you for that. And our last speaker, Dr. Pratesh, gave us an overall view of dementia care from community mental health perspective. And I think that was just fantastic. Lot of take home points for us, maybe to think about what can be implemented both by the public and the private health sector. And right now I see that there are many models which encompass community care, inpatient, outpatient, palliative, end of life care, and also home care. This is all fantastic. I understood that I think a lot of our people are at different levels of dementia awareness. While this is happening in our country, I think the West, understandably, is far more advanced. And a lot of what they are doing is going to be coming our way soon. And I think we have to look at ways of incorporating some of those practices into our care models. And what I mean by this is we are going to be using biomarkers soon, I hope, genetic markers, be it your various PET scan, FDG scans, or we might be looking at use of lecanemab. What is the policy we have? What is the protocol we have to incorporate all this in our clinical practice? What is the level of training that we are all going to need? These are all things for us to think about. So I think for us to move ahead as a country, we need a coordinated approach at different levels. We need a national dementia strategy. I think Dr. Radhamurthy has paved the way forward for it. And of course, last but not the least, I think the focus should be on dementia-friendly communities, research for not just prevention, but also dementia cure. Thank you.
Thank you, dignitaries. It was a truly informative session. It's an honor to have such a informative session today. So I request Dr. Priya Raghavan ma'am to honor our speakers, and I request the speakers to kindly accept our small token of appreciation. Thank you, ma'am. Thank you, dignitaries. I'd also like to thank Dr. Priya Raghavan, ma'am. I request ma'am to kindly accept a small token of respect. I request Dr. Pratibha Pereira, ma'am, to do the honors. Thank you, dignitaries. Before I move on to the next session, there is a small message from Paolo Barberino, CEO, Alzheimer's Disease International, headquarters, Blue Lion Place, London.
Good morning, good afternoon, authorities, ladies and gentlemen. It is such a pleasure to be here with you today and have the opportunity to welcome you all to the ARDSICON 2025. This year's theme, Dementia, Policy, Practice and Progress, is especially important and timely as we find ourselves in a new era of advancements in dementia policy. And right now, we need to observe how policy can be implemented to lead to greater progress in the spheres of dementia care, support, and treatment. With every successful step, we are presented with fresh challenges. Indeed, the conference theme reminds us of the cyclical nature of our collective effort towards progress. I would like to specifically thank Renu Vora, ARDSI Chair, and Dr. Joshi, ARDSI Mysuru Chapter Chair, for all the hard work that has gone into organizing this inspiring and educational conference. From government ministers to researchers to family caregivers to advocates and members of the healthcare profession, we all have our role to play in improving the lives of those living with dementia here in India, but also globally. We should also take this moment to acknowledge and even celebrate how far we've come in the last decade. So far, India has 2 state dementia plans, in Kerala and in Karnataka. These plans have set the groundwork for memory clinics, caregiver support, the training of healthcare professionals, and much more. This is life-changing support for someone living with dementia in these communities, along with their families and carers. We must keep pushing towards the ultimate goal, a national dementia plan at the federal level for all of India. It is my sincere hope that this conference will reinvigorate India's national dementia plan progress and that we will soon see the launch of this plan, a plan that will positively impact the more than 8 million people living with dementia in India. Globally, we are continuing to see an alarming lack of awareness, especially within the medical professions, as highlighted in our World Alzheimer's report in 2024, with 65% of medical professionals wrongly believing dementia to be a normal part of aging. It is therefore more pressing than ever that we tackle the stigma, not least because it acts as a major block to people seeking out a diagnosis. Strong and robust dementia policy is also foundational to encouraging people to seek out a diagnosis and unlock treatment, care, and support pathways. While there is so much work still to be done, it would be remiss of me not to reflect upon the progress that we have made over the course of 2025. Pertinently, World Health Organization's member states voted to extend the Global Action Plan on the public health response to dementia in May at the World Health Assembly. This positive step will continue to ensure that dementia has a standalone mandate as a critical public health priority. This is essential to continue our work of advocacy with governments, as it gives ADI the capacity to formally hold governments accountable on their response to the global plan. The other big success was the inclusion of dementia within the political declaration of the 4th high-level meeting on the prevention and control of NCDs and mental health at the United Nations General Assembly in September. Both of these accomplishments will have a ripple effect on our work going forward, the latter in the form of a new advocacy toolkit for our association in 120 countries, to leverage the new declaration, including access to NCD budgets. We are also gearing up for our 37th annual global conference in Lyon, France in April 2026. As the longest running international conference on dementia, this event will host a world-class lineup of international keynote speakers, showcasing the best dementia solution for today and for tomorrow. ADI was delighted to receive more than 1,000 abstract submissions, which will shape the broad range of topics featured in our parallel program and poster exhibitions. We hope quite a few of you will join us in Lyon and inform us of the great work on dementia and Alzheimer's that is taking place in India. In conclusion, I hope that this conference allows everyone the opportunity to partake in thoughtful and meaningful discussion, ideas, and knowledge exchange. Together, with our joint expertise and knowledge in many areas, we have the opportunity to push forward dementia progress, not just here in Mysuru, but in India as a whole. I wish you all a fruitful conference. Goodbye.
I thank ma'am for such a motivational message. I now welcome Dr. M. Premanath sir, Senior Consultant in Internal Medicine, Mysuru, and Dr. Purushottam Shastri sir, former Professor, Department of Orthopedics, Jesus Medical College, Mysuru, to chair the session titled A Gentle Reminder That You Don't Need a Perfect Memory to Live a Meaningful Life by Dr. M. A. Shekhar sir, former Vice Chancellor, Adi Chunchandgiri University, BG Nagara, Mandya. I request the chairpersons to introduce our speaker to the gathering. Over to you, sir.
I think Dr. Shekhar doesn't need any introduction to the doctors of Mysuru. In fact, I was already instructed not to spend a lot of time in introducing. Everything is there on the screen. But what I want to tell is Dr. Shekhar is known for his out-of-the-box thinking.
Oh, I am out of the box.
He's a wonderful speaker. You can look at the title of his speech. That is also out of the box. You don't need a perfect memory to live a meaningful life. A gentle reminder. I think it is definitely out of the box. Dr. Shekhar, please.
Thank you, sir. Good evening, everyone. Jai Shri Gurudev. Let me tell you, you will be surprised that I'm going to talk nonsense. Anyway, to start the ball rolling, all of you, please look to the left and right and smile, please. Look to your left, look to your right and smile. Don't look at a boy and a girl should not smile. Otherwise, it's fine. You all did it? Good. My predecessor was saying most of you are sleeping. I hope I made you wake up. Now, two things in the first slide. First one is ARDSICON. God bless you. I only got ARDS part of it. I thought it is acute receiver distress syndrome. Having listened to stupid people like us for the last 2 days, I'm sure you're all distressed. Don't worry, I'll make it very, very nice. And don't worry, most of you are young, not old like me. You will not lose anything. Next, when Tejaswini called me and said, you are supposed to speak on this. No, sorry. You are going to speak on this. I said, what are you doing? You want to sacrifice me in front of young people? She said, no, sir, please go ahead. I took some time, and what I did was, if I say you, it becomes paternalistic. If I say you, it becomes an order. So we have changed it into we. Okay? It's we. We don't need a perfect memory to live a meaningful life, a gentle reminder. Good. My English is good. I came across this. I read a signboard in whatever place. You can put it in Mysuru, Bangalore, wherever, at a shop, which said J Rocks. Youngsters would definitely get the idea. I spent next half hour, I spent for this topic at least half a week, 3-4 days, trying to figure out what and who Jay was and what was he or she rocking. Can you tell me what it is? It's, you all know about it. Stupid fellows. So this is the mindset I had when Tejaswini gave me this. I didn't know I was rocking or jaying or whatever it is. End of the day, it is this. Now, ladies and gentlemen, carefully you see the next slide. It's a personal disclosure. This talk is how I have understood this long topic. Post chat GPT, post perplexity and all those funny things. I remember 30, 40 years ago, I was asked to give metformin, good or bad. Diabetes, microvascular disease. Today, it runs to 3 or 4 lines. The heading itself runs to 3 or 4 lines. I don't think you have picked it up from ChatGPT. Have you? No. Good. This is my next disclosure. What's it? Brain remembers insults for 20 years, but forgets praises in 30 days. So at the end of my speech, if you insult me, I'll remember you forever. Okay? So if you praise me, it doesn't matter. I will forget it because I'm old. And now let me tell you, after Tejaswini asked me to speak on this, thank you. Thank you, madam. You woke up my MCI, not Medical Council of India, mild cognitive impairment. I wouldn't know what I'm supposed to speak. And today I'm overdressed probably. But let me tell you, I dressed it myself, not my wife, not my children. So I don't have MCI. Good. Now let's see. No conflicts of interest. They are not giving me money, stupid people. These are the 3 or 4 phrases or words, which is what I'm supposed to speak to you. Okay? Sorry if I put my back to you. I thought I'll stand there because there are not anybody there, but some people have already gone. So I'll stand here only. So imagine memory, perfect memory, memorable life, living, gentle reminder. To really understand this, you should need MA English degree. Not psychology, psychiatry, medicine, etc. But still, I went through all these funny things, science of memory, how to keep it, blah, 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 and so on. And end of this, having done it for 7 days to 10 days with so many references, what happened? This happened. They allowed me to brush my physiology, neurophysiology and neuroanatomy. And I said, what? Can you imagine? I can't even understand my own brain. Can I speak nicely on this? This was my unfortunate status. Okay. I have made it very easy to you. What is memory? The brain's ability to store whatever inputs you get, retain and recall information or experiences. Very simple. What is memory? That's it. Simple. So you've already got 5 marks out of 10 if you're asked a short question. But it can mean different things depending on the context. Biological, psychological, and technological. Biological, you all know. The neurochemicals, the neurochemistry, neuroanatomy, neurophysiology of biological part of memory, we all know. Dopamine, all those funny things. I'm not going to confuse you. Psychological, I'm going to talk a little bit more. But technical, did you know about this? Technical memory? Hey, come on, guys. Without which we don't work. So-called stupid computers, technical memory. So I said, let me convince the youngsters in the hall or the family, these 3 components of memory. She didn't tell me human memory. You said only memory. So I thought I'll put this: human, computing, technological, and AI. You can read. Short-term AI memory, long-term AI memory. God bless you, I do not know much. But primary memory, we all know, random access memory. And secondary memory, storage, USB, hard disks, all those funny things, But what's important? Human memory. Okay? In human memory, these are the components. Sensory memory. You call me, immediately I say, oh, this is Tejaswini. Oh, this is Sheba. Is Sheba around? Yeah, you're here. She's there. Good. 2 days later, when they call me, if I am not, recorded the number. Who are you? That's sensory memory. Short-term memory and long-term. Two things, explicit and implicit memory, which is very important for medical allied subjects. Explicit memory, you know, facts and figures, we all know. But implicit is how to put it into practice, and that's what all these predecessors were talking about, right? So with this human memory in our mind, let's go further. Life, meaningful life, one of the most fascinating and complex functions of the brain is memory, God bless you, allows us to learn, adapt, and form sensory identity. These are all not medical terminology, it's all philosophy. But I picked up some of the statements. I think I should read it for all of our acceptance. What matters most is not how perfectly we recall the past, but how openly we engage in the present. Everybody talks about it. Whatever dharma you profess, don't worry about what happened in the past. It doesn't matter. But what engagement you do in the present is very important, because what you do today in 1 day, 2 days, 3 days becomes the past. So what you do today, don't worry about what happened in the, at the age of 10, I did not know how to put my socks. Doesn't matter. If you know how to put your socks, it becomes a past memory in another few days. Beautiful, no? Good. Life's depth comes from connections we make, the kindness we offer, and moments we choose to savor. That is meaningful life. But even with imperfections, forgetfulness, or gaps in our recollection, we can still experience purpose, joy, and growth. You agree? Yes? How did you agree? I didn't give you money. All you did was look to your right and left and smile. That's an imperfection. We did not know the person sitting by my side may be a stranger, but we still enjoy looking at them, even if they are ugly like me. Meaning is found in living and not in remembering every detail. That's the final statement I would like to tell you today. Meaning is not how much you retain as memory, but how to live in the present and make it a pleasant memory in future. Okay? Now, what is perfect memory? She has asked me to talk about perfect memory also in the component. Eidetic memory, photographic memory, total recall, blah, blah, blah. Every detail of every experience exactly as it happened without distortion, forgetting, or error. Can anybody stand up on the bench and tell me you have perfect memory? Forget it. Absolutely no. Every detail, every experience exactly as happened. You see me 3 days, 4 days later, you don't know whether I'm wearing a green one or a black one because everything is black in me. That's it. That's not perfect memory we are talking about. You agree? Now, highly superior autobiographical memory, HSAM, is a technical word for that. Ability to remember everything accurately forever. Forever means even after you're dead, your soul remembers. Hyperthymesia is something you should know. Some people have this to a certain extent. Cannot forget painful events. I told you, you insult me, 20 years. You praise me, 30 days. Painful. If I insult you people, it's a painful experience, a memory you will, that is, if you go on happy, oh, he called me like this, oh, he did that, etc. like that, it becomes hyperthymesia. These three are perfect memories. Don't bother, none of us have it. But human memory is designed to be meaningful, not perfect. Our memory is to be meaningful. Let's go to that level next. And finally, perfect memory is neither normative nor necessary. What is normative? For your growth and development. What is necessary? To live. It's not required at all, right? This is my statement. It may not exist. I don't have perfect memory. How many of you have perfect memory? None of us have. Now, it's imperfect. That's what I wanted to tell you next. Reconstructive, not photographic. Prioritizes emotion over accuracy. You agree with me? You've seen a movie, Kantara. You prioritize the memory of Kantara movie by the emotions you have had in the movie, not the accuracy. Oh, he had a tummy, his thighs were very thick, he had a huge beard. We don't have accuracy memory, do we? But we have that emotion of that fellow screaming, "Ah!" Something like that, right? Evolves to serve meaning and survival, not perfect recall. It's imperfect because of these three concepts, okay? Forget details. That's something you should know. When we talk about memory, whether it's meaningful or not, what is interwoven into that? Forgetfulness, without which you would have committed suicide in 3 years. I'm sure. Now, what is forgetting? Active, functional, biological system, filtering, emotional reset, cognitive flexibility. God bless you. I just copied it from all those journals that I got it. But what's important is filtering noise. Don't you agree? I have been talking for the last, I don't know how many minutes. You are filtering the noise. You are appreciating my jokes, forgetting about normative, cognitive, minimally mild, all those things. Very important. That's the most important concept of memory making. Emotional reset. 3 days later, hey, Shekhar was very good, I say. He spoke so nicely. What he spoke, God bless you. So that's it, okay? Value, adaptive neural features, etc. But what's important is forgetting helps us to heal from emotional pain, reduce mental overload, stay focused on the present, and prioritize important information. You all agree? So memory is important or forgetting is important? How many for memory? Put your hands up. How many for forgetting? You should put both hands up. Both are important. Two faces of the same coin. But you should remember, everybody says, eh? Very good. You are a good geriatrist, not gerontologist or geriatric specialist. They say two faces of the same coin. Everybody says we are so inseparable, two faces same coin. Stupid people, you will never face each other. If you are the two faces of the same coin, you are always opposite. Okay. Now, meaning making. How do you make meaning out of the memory inputs that you have had? Is really science. Meaning, narrative identity, presence and awareness, values and action, emotions. I'll give my slides to every one of you. You can go and do your due diligence of theory. But what's important? Hey, I'll hate this fellow. Okay. Do you want me to stop? Come on. If you do that, I'll. Meaning emerges through narrative identity formation. I'm narrating something. You identify yourself with that and you form something. That becomes memory. Attention and mindful presence. You are here, not thinking of pizza, not thinking of some movie, not thinking of your father screaming at you in the night. Value-based action and engagement. Once you go out of this, all these people were talking about how to engage the community, how to help. There were some videos you just saw. How do you engage after you have learned is something you should have, making that. Don't worry, coherence, purpose, significance. I can go on talking nonsense. Now, important is meaningful life. How many of you have had meaningful life so far? Old people will raise their hands. Young people, say yes. You have had meaningful life. That meaningful definition is something difficult to define. If you are happy, when you are happy, if is something, if should not be used in conversations. When you are happy, when you make people happy, when you have achieved things, the goals that you have set to yourself, your life becomes meaningful. I really thought I would put Kavi Bhatta, then I decided no, it's not necessary. The core elements, blah, 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 purpose, connection, growth, contribution, all these funny things. But what's important is connected to others. Meaningful life is about connecting yourself to others. Who are they? Your parents, your siblings, your neighbors, your community, and people on Mars. It will happen. Guided by purpose. What is the purpose of an undergraduate? to get their degree. Postgraduate, to learn implicit memory and get a degree. Doctor, to make a lot of money. In 3 years, 3-storied building. In 2 years, 1 crore rupee worth of a car. God bless you. Enriched by growth, not becoming taller or fatter, being present and true to who we are. I am a doctor, I should be true to myself. I'm an engineer, I true to be myself. I'm a thief, I must be true to be myself as a thief also. It's important. Okay? That's it. Key elements, having sense of purpose. These are all theory, man. Don't worry. So what is memory? I've just given you an idea. What is life? You will experience it throughout your life. I have very little time left. Maybe, God bless, whatever. But you guys have decades. So think of it. Make it meaningful. How? I've just given you an idea. Okay? Now, I've come to the end. Don't say ting. Summing up, what is meaningful life and gentle reminder is gentle and simple. Perfect memory is not needed to have a meaningful life. It's gentle and simple. You don't need perfect memory. All you need is how you have internalized your experience as a good memory, how you are externalized the bad memories out of your system. That is gentle and simple. Poetic. I just added. It's not built on flawless memory, but on small moments of courage, compassion, and connection. Like it? Say yes. Yeah, good. Philosophical. Perfect memory is not a prerequisite for a purposeful life. Meaning comes from how we live, not how much we remember. Funny. But what's important is the final question. Is perfect memory needed for living a meaningful life? The final answer is no. You all agree? Good. Thank you. But if you still think perfect memory is needed, become an AI or a computer. Don't be a human. Right? If you're a human, don't bother. Now, last slide. Who is this? That's me. I came here smiling. I stood here smiling. I spoke smiling. I am walking out smiling. But these were the audience. Those who knew me. Hey, good speaker, Kana, Shekhar, yen ankomuttevna. Those who have heard from their friends that I am a good speaker. Those want to know whether I am a good speaker or not. And those who have already experienced, stupid fellow, it doesn't. This is what you are all today. You love me, you like me, you think I'm going to be good, and you think I'm not good. But now, please don't go out of this hall with this. Either internal or facial expression. Thank you. Another thing, applause should be voluntary from the heart. Just because I said thank you.
I think that was a wonderful talk. And Dr. Shekhar is very well known for this out of the box things. And he has made it very clear. I think you made it very clear that perfect memory is not necessary, but at the same time, probably meaningful and purposeful life. A moderate memory is enough to lead a meaningful and purposeful life. If at all, if you recall all the successful men around the globe, whether it is in academic field, philosophical, spiritual, or political, all of them had mediocre memories. All those who have achieved throughout the world, not a great intellect has ever achieved except a very few, that is in single digits. And Sir MV is one of them, one of the rarest of the rare one. So I think the topic was I think she must have taken a lot of time to put it across. That too, the selection of the speaker was good. And I think with this, he has done justice to whatever the topic was given to him. And he has made it very clear, and he has made it, he has made things very clear for the listeners here, because we can lead a purposeful life, because a meaningful life, because most of them do not have perfect memory. And an average, one thing is forgetfulness is a bliss. In fact, as to the present term, to forget and forgive than to have a perfect memory is better. That is how it is. Even the philosophy also puts it across. The long time we remember, it becomes divine. Whatever we remember of what happened in the past, it has become divine now. That is the perfect memory. And yeah.
You remember what happened 20 years ago?
Yeah. So, any questions, please, on the floor about this?
Beautiful closure to the journey of memory we took the students. So, in all, we should not be mindful, but we should be mindful.
No, Shekhar always picks up two things. I worked very closely with him. I was in his clinic for more than 5 to 6 years practicing with him. He always used to tell two things that are very meaningful for life. One was common sense and maturity. And that's what I picked up in the late 90s when Shekhar spoke about this. I think Premnath, very senior man, I think one of those elder brother. He's also a very great speaker, because though he is in private sector, he has put up so much of impact on academic things. I think he has got something to say about this.
You will all agree with me, with Dr. Shekhar. I told you that he will be a speaker who will entertain you out of the box thinking. Beautiful, Shekhar. It is wonderful. Thank you so much.
I think there should be some questions to cheer up. He can come out with many things.
Convert that into permanent memory, or there is no need as such. The brain is already full. What is your take on that?
You mentioned one example, selective memory. You had a very nice lunch today. How do you make it long term? Is it necessary? That's the first question you ask. Whatever selective memory you have had, is it necessary to be made long term? That's the first step you take. If you think you had the best lunch of your lifetime, you keep it long term. What do you do? Just write it down. I had soup, best of the soups. I had salt, best of the salt, whatever it is. Otherwise, the selective memory you're talking, if you are a doctor, I remember, can I take this time? In the 90s, when I started my clinical practice, 89 to be precise, in the very early time, I had one ICS, Indian Civil Service retired person from Tamil Nadu, settled down in Mysuru. I started telling him I was young, not white bear, a lot of curly hairs, and they thought I'm not an Indian. He asked me, how do I live? I said, Angmadu, do this, do that, etc. He stopped me and said, Doctor, do you have diabetes? I said, no. Then you don't know much, doctor. Why don't you ask me to stop breathing? So what is this selective memory? You learn from the patient and you make it long term, and I have done it for the last 30 years of making it simple. I call it for our postgraduates as KISS principle. Keep it simple. One more S is stupid. The stupid is doctor. So the selective memories, you want to make it long term. Either you record it, you write it down, keep reading it. My mother told me, please read aloud. I didn't know why. She thought I would go off to sleep if I don't read aloud. But she was ping me. You know, when you read silently, occipital lobe is stimulated. But when you read aloud, temporal lobe, occipital lobe, retention is better. something like that. 5,000 rupees, please.
Thank you, sir, for a wonderful session. It's an honor to have Dr. Yami Shekhar sir with us today. We request sir to accept our small token of appreciation, and I request the chairpersons to hand over the memento and honor our speaker. Thank you, sir. We thank Dr. M. Premnath sir and Dr. Purushottam Shastri sir for chairing the session. May I request Dr. Hanumantacha Joshi sir to present a small token. Madam, I request Pratibha ma'am to present a small token of respect to our chairpersons. Thank you, dignitaries.
ಇದು ತಗೋ. Thank you. I want to acknowledge one of our seniors to reach over to what I could be. With this, we have come to an end of the scientific session of day 2 of our ARDSICON 2025 International Conference on Dementia, Policy, Practice and Progress. I thank the speakers, the chairpersons and the delegates for making this event a grand success. I'd also like to express my gratitude to the organizing committee of the event for enabling us to learn and carry great knowledge regarding dementia, its policy, practice, and progress. It's now time for the prize distribution to the winners of oral and poster presentation and the valedictory event of ARDSICON 2025 International Conference on Dementia, Policy, Practice, and Progress. I request all the gathering to please be seated in the center of the stage. Thank you. I request the gathering to please be seated in the center of the stage. Sorry, center of the auditorium. I'm sorry. I now welcome Dr. C.P. Madhu sir, Director, JSS Hospital, Mysuru. Dr. Radha Murthy ma'am, President, Dementia Alliance, Co-founder, Nightingale's Medical Trust, Bengaluru. Mrs. Venu Vora ma'am, Chairperson, Alzheimer's and Related Disorders Society of India, New Delhi. Dr. Pratibha Pereira ma'am, Head, Department of Geriatrics, JSS Medical College, JSS AHER, Mysuru. And Dr. Head Joshi sir, Chairman, LOC, ARDSICON 2025 and Principal, Shardavilas College of Pharmacy, Mysuru, to kindly occupy seats on the dais. I'd also like to welcome Dr. Shilpa ma'am and Shri Ganesh GS sir on the dais. I'd also like to welcome Shri Ganesh Rao sir for the event. By seeking the blessings of His Holiness Jagadguru Shri Shivaratri Deshi Kendra Mahaswamiji, I wish you all a very good evening. Every ending is a new beginning. As we conclude this conference, let us carry forward the knowledge, inspirations, connections we have gained, turning them into action for a brighter future. With this, I welcome you all to the valedictory function of the ARDSICON 2025 International Conference on Dementia, Policy, Practice and Progress, organized by Alzheimer's and Related Disorders Society of India, Mysuru chapter, together in association with Department of Geriatrics, JSS Hospital, JSS Academy for Higher Education and Research, Mysuru, Shardavilas College of Pharmacy, Mysuru, and People's Association for Geriatric Empowerment, Mysuru. With this, let's begin this event with a melodious invocation. May I now request Dr. Ram Prasad sir for an invocation.
वन्देऽहं शारदा विशारदा ज्ञानदां वरदां वन्देऽहं शारदा विशारदा ज्ञानदां वरदां वन्देऽहं शारदा विशारदा ज्ञानदां वरदां वन्देऽहं शारदा शुद्धसत्त्वस्वरूपिणी स्वच्छहृदयनिवासिनी शुद्धसत्त्वस्वरूपिणी स्वच्छहृदयनिवासिनी स्वप्रकाशरूपिणी स्वप्रकाशरूपिणी वन्देऽहं शारदा परावेद्यभूषिता सुरवर सुजन सेविता शुभधाम सुलभा सुस्वरवाद्यां निरता वन्देऽहं शारदा शुभधां सुलभां सुस्वरवाद्यां निरता वन्देऽहं शारदा विशारदा ज्ञानदां वरदा वन्देऽहं शारदा वन्देऽहं शारदा वन्देऽहं शारदा.
Thank you, Dr. Ram Prasad. May I now request Shri Ganesh Rao Sir, Secretary, ARDSI Mysuru chapter, to welcome the gathering.
ಈಗ ಸಮಾರೋಪ ಸಮಾರಂಭಕ್ಕೆ ನೀವೆಲ್ಲ ಸಾಕ್ಷಿಯಾಗಿದ್ದೀರಿ. ಈಗ ಡಾಕ್ಟರ್ ಹನುಮಂತಾಚಾರ್ಯ ಜೋಶಿ ಅವರು ಈ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿದ್ದಾರೆ. ಅವರಿಗೆ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಶ್ರೀಮತಿ ರೇಣು ಅವರು ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಆಸೀನರಾಗಿದ್ದಾರೆ. ಅವರಿಗೂ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಡಾಕ್ಟರ್ ಪ್ರತಿಭಾ ಪೆರೇರಾ ಮೇಡಮ್ ಅವರಿಗೂ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಶ್ರೀಮತಿ ಶಿಲ್ಪಾ ಮೇಡಮ್, ಡಾಕ್ಟರ್ ಶಿಲ್ಪಾ ಮೇಡಮ್ ಅವರಿಗೂ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಡಾಕ್ಟರ್ ತೇಜಸ್ವಿನಿ ಮೇಡಮ್ ಅವರಿಗೂ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಡಾಕ್ಟರ್ ನಾಗೇಂದ್ರ ಅವರಿಗೂ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ನಿಮಗೆಲ್ಲರಿಗೂ ಈ ಸಮಾರಂಭಕ್ಕೆ ಸ್ವಾಗತವನ್ನು ಕೋರಿ ನಿಮ್ಮ ಈ ಸ್ವಾಗತ ಭಾಷಣ ಮುಗಿಸ್ತಾ ಇದ್ದೀನಿ. ನಮಸ್ಕಾರ.
Thank you, sir. A warm welcome to you too. May I now request Dr. Shilpa Ma'am, Joint Organizing Secretary, ARDSICON 2025, Mysuru, to present the conference report on the International Conference on Dementia, Policy, Practice and Progress. Over to you, ma'am.
A very good evening to one and all. Seeking blessings from His Holiness Jagadguru Sri Shivaratri Deshikendra Mahaswamiji, it's a privilege to present the conference report for last 2 days. With Shekhar sir in front of me, I have a privilege that I can miss something. So it's okay to, if I miss some names or something in the report. So that's a blessing for me because it's an instant report on table. So I'm happy Shekhar sir is there to guide me. Well, so ARDSICON 2025 was successfully conducted for last 2 days with enthusiasm and a great academic rigor from all of us, having around 250 delegates who were here and they were online and offline. We had around 31 chairpersons, experts who had joined the sessions. We had a lot of poster presentation and as well as the oral presenters as well. So ARDSICON 25 began with a collaboration between ARDSI Mysuru chapter, Department of Geriatrics headed by dynamic Pratibha ma'am, JSS Hospital, and then Page as well as Sharda Villas College of Pharmacy. ARDSI Mysuru chapter, of course, the first and foremost, I would say it was Hanumancharya Joshi sir who came and approached the department. Definitely that is through Pratibha ma'am, and it was a collaborative teamwork from all the 4 involved here with the blessed venue of JSS Auditorium, and that is how we could start we could plan ARDSICON 25 in JSS. So ARDSICON 25 was a mixed collaboration of lot of scientific session, symposium, debate, and panel discussion. And I must say it had a very great cultural extravagance also. To have a highlight of day one, yesterday we all began, of course, few minutes late because day one session, we had inaugural speech or a lecture by Dr. Vijetas, who spoke about the unraveling biology of Alzheimer's, which was a must, and it did set a good basic foundation for us to go ahead next, which was followed by Dr. Yogesh sir, who spoke about the biomarkers of the Alzheimer's disease. This was followed by a formal inauguration, which was presided by our Vice Chancellor Baswan Gaudappa sir, CP Madhu sir, Director of the hospital, Renu Ora ma'am, Hanumantachar Joshi sir, Pratibha ma'am, and all the organizing committee members in the inaugural ceremony. The inaugural ceremony was followed by extravagant or rather a dynamic debate between a young dynamic Dr. Shastara, who spoke more about cure in Alzheimer's, and we had Dr. Steve, who spoke about care is more important than cure. So finally they agreed upon care and cure is hand in hand, and we both have to walk in treating Alzheimer's. Then came we had HOD from AIMS Neurology Department, Manjari Tripathi ma'am, who spoke about how do we prevent more than the care and cure. It is about prevention of Alzheimer's and what are the risks, how do we risk modify, and how do we prevent Alzheimer's in a much younger age group. And that was followed by Prabha Adhikari ma'am, who spoke about what is the perspective of geriatrician in Alzheimer's disease. Adding to this, we had Dr. Trishala, who told about the cognitive reserve in us. How do we preserve the cognitive reserve? And she did mention about a lot of home exercises, which we all can start doing so that we lead towards perfect memory. And then we had our dynamic endocrinologist in-house, who spoke about dementia and diabetes, which was just before lunch. And then we all headed for a lunch, which was hyperglycemic with very, very delicious, my favorite, gulab jamun. So we had high calorie diet, which was definitely relished by most of us, followed by a postprandial session, which was a panel discussion. This was coordinated by Dr. Naina. So Dr. Naina did coordinate really well, and we had in the panel, we had a geriatrician, and we had social activist, occupational therapist, as well as a psychiatrist. So panel discussion was followed by Sailesh Mishra sir, who spoke about the dementia care homes, and he did mention about the ethical frameworks for the dementia care. So we did conclude the academic session like that last evening. And then we had a cultural feast around 6 o'clock, which happened in the old auditorium. And I must appreciate Dr. Kshama and team for the whole of the cultural organization, which initially began with the invocation, and we had a great cultural performance, a Bharatanatyam performance by the students. And we had a Mahabharata scripture, which was depicted in the form of dance by the very great artist from the Sharda Vilas College of Pharmacy. We had our own JSS Medical College students who did present a skit about dementia and did give a performance on the folk dance. I remember Dr. Kshama was very particular in maintaining the heritage tag of Mysuru, and we did give most of the importance was for our own culture. It was more of culture, folk, and classical, which was all put into the cultural feast. And cultural feast was compared by our very own postgraduates, Dr. Ashrita and Dr. Ram. They did a great job. And so with the cultural event, again, we did all have a good light dinner. And then that is how we winded the day one. And day two began with the topic which most of the clinicians are not very fond of. I'm sorry. I think day one, we also had, parallelly with these sessions, we had oral presentation, platform presentations, as well as online presentations also. And this was run very smoothly by the scientific committee. I give complete credit to Dr. Tejaswini ma'am, who coordinated the whole scientific sessions, the competitions and everything, along with Dr. Seema, Dr. Nagendra sir from Sharda Vilas College of Pharmacy. I might miss some names because I'm not very good in remembering few names. So I have Shekhar sir to back me up for that. So day one, we did have these sessions, and then day two started with a session by Dr. Akila Prashant, who's professor of biochemistry. The topic was proteomics and genetics, which is a topic which we clinicians are not very keen on, but that was a great beginning, and she did give us lot of insight on what are the biomarkers available now and which how approachable and feasible it is. That was followed by an anti-amyloid therapy. How far do we go, by Dr. Amir Moin, neurologist from Apollo. And this session was followed by followed by diet and mind, how diet helps the mind, and that was by Dr. Shweta Shri from Department of Nutrition in JSS Hospital. And these sessions were then, we did have an online session by Dr. Saharia, who spoke about the WHO framework on how do we implement the dementia care in India. And we also had Meera Patabiram also gave an online session about the dementia. And then we had Professor Naganand from JC College of Engineering, who spoke about AI in dementia. He did mention that we'll reach that scenario where we go to AI for a second opinion. I hope it shouldn't happen the other way around. So, and then we had a professor from speech and hearing who spoke about the newer insight about the technology into cognitive assistive devices. And then we had Dr. Sundaram, who spoke about the legal practices, how do we implement in the public about the dementia care plans. And of course, these sessions were followed by advanced medical directive, which was very much needed for geriatricians, especially in our day-to-day practices, by Dr. Vishwanath from Ramaya Medical College. And these sessions were then followed by, we had a lunch break, and then we had a panel discussion about community care models. What do we practice in Mysuru? What is the idealistic community care models? And then, not to say much, we had a dynamic last session, and it's very difficult to speak when Shekhar sir is in front of you. He spoke about it's okay to forget something. So I have completely taken the privilege to miss few things, and I mean that's something very good. So now we are in this validatory function. We have reached the conclusion, and then probably we are here to appreciate those who have achieved, and there are prize winners in this oral presentation or the platform presentation. Of course, end of these 2 days, I would definitely say that there is a sense of fulfillment for all of us in the organizing committee, that we have tried to do our best. So if there are some things which we have missed, I ask for an apology for that. And on all these 2 days, we had stalls, and all our delegates, I'm sure they might have visited the stalls where we had accessories for the especially for the people with dementia. We had a stall about the food and also industries which displayed their brands, and they have contributed for the conference, for smooth running of the conference. We all relished whatever JSS Hospital canteen served us. We had no choice, but then yes, it was it was a delicacy. And on this 2 days, we had convener from KMC, Dr. Chetan, who has been a silent observer, and we did miss welcoming or thanking him formally, but then he has been there for last 2 days, and I extend my thanks to you, sir. So with this, we come to the conclusion of these 2 day conference, and waiting to have more of such conferences in the future. But then let's be in the audience than in the organizing team. So thank yeah, thank you very much, and we look forward for the next prize distribution and presidential address. Thank you. Thank you.
Thank you, ma'am, for beautifully reporting all the events of the conference. May I now welcome Dr. Radha Murthy, ma'am, President. May I now request Srimati Renu Ora, ma'am, Chairperson, Alzheimer's and Related Disorders Society of India, New Delhi, to kindly address the gathering.
Good evening to all of you. Dear delegates and friends, as we conclude ARDSICON 2025, I want to express my heartfelt thanks to each one of you for your active participation, and my greetings and good wishes to all the dignitaries, including my colleague Dr. Joshi. This year's theme, Dementia, Policy and Practice Progress, brings clinicians, researchers, policymakers, caregivers, and advocates onto one platform, and we have learned a lot from them. Let us carry forward this learning and connection, and renew our resolve to strengthen dementia care across India. Thank you very much.
Thank you, ma'am. May I now request Dr. Pratibha Pereira, ma'am, Head, Department of Geriatrics, JSS Medical College, JSS A HER, Mysuru, to kindly address the gathering.
As we conclude 2 days of fun, food, and learning, I want at the outset, I just want to thank Dr. Hanumantacharya Joshi, for asking us to be a part of this conference. Thank you so much. If he had not come and asked me, we would not have been standing here and being a part of this wonderful learning session. Together, we have done a lot of activities, and future is open and bright. We have already things planned up, and our next agenda is to make Mysore elderly friendly city tag, and we are planning to apply for that. So let's give Dr. Joshi a big hand. And I want to thank all the team members in all the committees. Without your support, it would not have been possible. And I told them, no, I'm just going to mentor and Ashirvada. And that's exactly what I did every time. Ashirvada. I said, no, don't worry. It'll happen. And I want to give the team a big hand, all. Great job, well done. And what is a conference without an audience? And you'll have the first day, second day, and on the valedictory day, so many being here. 3 cheers to all of you all. I want to cheer because without audience, there's no conference. At the end, with the blessings is always necessary. Almighty and Sri Deshikendra Mahaswamiji and all who are here, elders, with their support and blessing, we go back from the conference with a smile. And any small things has happened, I ask for forgiveness. Badi conference mein choti to hoti hai na. So I borrow Shah Rukh Khan's dialogue. With that, I end this. Happy Sunday.
It's now time to honor the winners of the oral presentation. The third place goes to Ms. Ganavi KN, PhD Scholar, Department of Geriatrics, JSS AHER, Mysuru. I request Renu Ora ma'am to do the honors. The second place goes to Mr. Charan Raj N, Department of Pharmacology, Faculty of Pharmacy, MS Ramaya University, of Applied Sciences, Bengaluru. I request Dr. Pratibha Pereira ma'am to do the honors. The first place goes to Dr. Rami Reddy Gari Harith Reddy, Department of Emergency Medicines, JSS Hospital, JSS AHER, Mysuru. I request Ganesh sir to do the honors. It's now time to honor the winners of the poster presentation. The third place goes to Dr. Raghavi Mishra, first year postgraduate, Department of Geriatrics, JSS Medical College and Hospital, Mysuru. I request Shilpa ma'am to do the honors. The second place goes to Ms. Vinuta YP, student of 5th PharmD, Shardavilas College of Pharmacy, Mysuru. I request Tejaswini ma'am to do the honors. The first place goes to Mr. Prajwal B, PharmD intern, Shardavilas College of Pharmacy, Mysuru. I request Dr. H. Joshi sir to do the honors. I request Dr. Nagendra sir to also join. I congratulate all the winners and thank you, dignitaries. May I now request the feedback from the audience? I request Vinuta YP from 6th PharmD SVCP to kindly provide her feedback.
Remember that caregiving teaches you patience and love that never knew was possible. Good evening to one and all. I am Vinuta YP, 6th year PharmD from Shardavilas College of Pharmacy. I am delighted to share my experience on ARDSICON 2025, an international conference on dementia, policy, practice, and progress. First of all, I would like to thank the organizers, resource persons, and our college for giving us a wonderful opportunity to participate in this conference. Attending this conference has been a truly an enriching experience for me and all of you, I guess so. Over the last 2 days, we were exposed to valuable sessions on dementia and the role of healthcare professional in patient care. These sessions were not only informative but also be practical and help us to understand how the knowledge from our academics or the curriculum can be applied in real world clinical evidence. This conference was helped me to improve my confidence and to improve my communication skills and to build a better knowledge about the interdisciplinary collaboration. Overall, this conference was an inspiring experience for me and shaped my academic perspective and encouraged me to pursue the clinical excellence. I sincerely thank my lecturers, my institution, and the organizing committee for their support and making this event more memorable. Thank you.
Thank you, Vinuta. May I request Dr. Harith Reddy, emergency physician, JSS AHER, to kindly provide his feedback.
think I'm audible. Hi, I'm Dr. Harith. I'm an emergency physician. Most of you would be thinking, why is an ED physician here? So that's what everybody asked me when I told that I registered for a dementia conference and I'm presenting a paper. So I have two reasons for attending this conference. We always have our reasons, right? One was the professional perspective. Like we have the growing dementia numbers and we don't have the advanced directives or we don't have the wills to say what are the treatment we are giving. So should I escalate? Should I not escalate? That's a decision I always have with Pratibha ma'am. All through the 5 years I've been here, every time I call her, ma'am, so and so case has come. I want to intubate. She'll be like, Harith, hold the horses. No, Baba, don't intubate as of now. So that's one learning experience about how to look at the perspective on a professional level. On a personal level, if you think, I mean, majority of us have elderly at home. Majority of us have seen one or two of our family members suffering from this, right? So I had a very good time with my grandfather. When I was in MBBS, he was at the end stage of his life. He was diagnosed with frontotemporal dementia. I've seen him going through a lot of stuff and it hit at the emotional level also for that reasons. So once he passed away and recently my father got retired from his profession. So there are times or the triggers that he says like, I'm not able to find the keys. I don't know where I kept my specs. Or when he says, I forgot my pen. Or he says, this was not the route I was going previously, no. So those kind of things really give you a lot of really heart attacks, even for an ED physician. So on a personal level, I wanted to invest more on how can we make it better. So the adult learning always happens in three domains. One is a cognitive domain, psychomotor domain, and an affective domain. So cognitive, the session, I mean, if I need to give a feedback of the sessions, definitely all of us will accept that there were some aspects of about how to go with the cognitive domain. Then we had aspects about affective domain, like the speakers shared their own parents' experience about how they were starting the exercise community and all. Coming to the psychomotor aspect, definitely we didn't try any skills as such, but maybe at the end, Shekhar sir has concluded that to live with not the full memory, but a meaningful life. So the psychomotor aspect is about finding the meaning of your life. So thank you.
Thank you, Dr. Harith. May I now request Daneshwari from MPharm, MS Ramaya University, Bangalore, to provide her feedback.
Good evening, everyone. Sorry that I don't have a great memory. That's why I brought a book over here. It was a great and to get an opportunity to attend this 2 days international conference. One of the highlight of the event is to get a chance to present my own research as a oral presentation. And beyond the oral presentation, I got to exposure over a different concepts of dementia. And the final speaker, Dr. M.A. Shekhar sir, that was really a good session. We really enjoyed it. And overall, the experience of a conference is enriching. And thank you so much.
Thank you, Dhaneshwari. May I now request Dr. H. Joshi sir, Chairman, LOC, ARDSICON 2025 and Principal, Shardhavilas College of Pharmacy, Mysuru, to present the presidential address.
Good evening, everyone. Dignitaries on the dais, off the dais, and dear students and delegates. A valedictory function makes someone remember. For example, whenever there is a marriage in India, it's normally a 2 days or 3 days marriage, and in the end, there is one program, Kanya Upsodu anta ಹೇಳ್ತಾರೆ. Andre we are sending, we are seeing off the couple. It's like that. So we had a wonderful get together. Number one, we had a get together of the great minds of the country, not only the country but as well as some people from abroad. It was really wonderful and fortunate to have Paula with us. At least for 5 minutes she joined from UK. We had Suharya, who leads Asia as far as ADI is concerned, and we also had Noria Vashiju. Of course, all people could not listen to her due to the sparsity of time, but we could take the fine points from that. And wonderful speakers. The major credit goes to the doctor who is sitting in the last, Dr. Tejaswini. We had a small chat. How many speakers from ARDSI, how many people from the scientific committee, and Madam called me, and we had a little difficult situation personally. So I requested her to go out, and wonderful speakers, and you can see. All people are talking about Shekhar sir. Shekhar sir is not new to us actually. See, now all the credit is taken by Shekhar sir. No, let us leave that. No, he's a wonderful man. We know very well. He's proud of our country as well as state. So it was a wonderful conference, and ARDSI has been doing a lot of activities throughout the year, as rightly said by Pratibha Madam. It is not only conducting an annual conference, let it be the mini mental state examination, memory screening, and mainly awareness and advocacy. Because in the beginning, only yesterday I told you that doctors are doing their jobs, right? We are highly thankful to them, but all cannot be done by only medical fraternity, especially these kind of diseases. That's where the community plays an important role. And in one of the slide, one doctor was saying that it is not only a doctor, everyone in the society has to be involved. That's what ARDSI is trying to do from past 15 years. See, for it can be an advocate, it can be chartered accountants, it can be the other people, any walks of life, even the housewife also. They are the members of ARDSI from a long time. And we have our chairperson Renu Voraji also. She has come all the way from Delhi for that. And thanks to you for giving us an opportunity, first of all, because there are always contenders, in the country. Now, chapters want to come forward and host the conference. We had hosted this conference in 2016 in Ayush, Indian Institute of Speech of Hearing, and we had Martin Prince, was the chief guest at the time. So this time we are very fortunate to have Dr. Pratibha Pereira. Madam, once we meet, there is no seeing back actually. On the spot decisions, on the spot planning. Only thing is we have to execute, right? That's the second point. So thanks to her and thanks to the team. And it has been planned for almost 6 months. We have been planning. When we requested Renuji during a meeting, they had been very courteous enough to give this opportunity. And finally, what we could carry, what we could remember, and what we're going to put it into practice, because title itself is there, policy, practice, and progress. Now we have to see the progress for the next 1 year, right? If you could do a little progress in way of a discovery, maybe research, or putting into practice, in the end, a proper cure and care, I think we have done the purpose, and we have met, the objective of the conference. And thanks to all the people. Of course, vote of thanks is remaining. But as a president of ARDSI Mysuru chapter and National Secretary of ARDSI, it's my responsibility to thank all the people who have been, especially the our JSS team. Shilpa Madam, you have seen her with perfection. In the beginning, she said, "I will not read the report; give it to someone else." Right now, extemporally, without forgetting anyone, and taking an excuse of Shekhar sir once again. Right, very clever idea. She could narrate everything, but from day one, planning of it can be anything. It can be the hall. It can be planning of the people with catering. Everything we have been associated, and I think we have disturbed you a lot, your personal time and every time. I think we have that liberty to do in the conference time. Thanks to you, and not only that, Shama, wonderful, the memorable, cultural program. It was not expected because the time was very short, but beautiful. And our dear friend Ajay sir, a calm and wonderful man, and says everything will be executed, in a wonderful way. And not to, forget and, not to forget our Sharda Vilas team, our energy, right? Our team work is always, it gives an impression, how the things are conducted. I repeat once, it's not only the conference, it's not only 2 days conference. Every activity, it can be Rotary activity, it can be a memory walk, it can be a trekking, right? Mingling in the people, right? The people are always there. And I will not take any particular names here because we are a team, and wonderful work, and especially my dear students, right? The farm day. And I think now you understood, right? You were hesitating a little. Why should we attend a medical conference, right? We are pharmacy people. Now you got an idea, right? See, this is where you have to be. You have to understand the aspects of it. And there are some beautiful talks, especially on the drug development, right? So thanks to everyone. And thanks to the team here who have been doing a wonderful work from past 3-4 days. And some people have not slept. 6 in the morning, 1 o'clock in the midnight, sending the messages, right? And I think I will tell now only. I thought I'll call for a separate meeting and I'll discuss. I think to some people I would have spoken a little harsher, especially my friends here, right? Some people don't take it. It's a learning time, because what we need is, if not perfection, as rightly said by Shekhar sir, at least near to perfection, right? So, society expects something from us. People expect something from us. We cannot give anything which is not, if not entire perfect, at least little perfection. So now that's what, it has reflected in our proceedings, right? Wonderful proceedings. Thanks to the scientific team and all the people who have involved. And so what else to say? It was a very wonderful and a successful conference. I should not say, but people should say. I think Renuji, you are satisfied. Yeah. So thank you very much. And so finally, before I conclude, next conference will be in Coimbatore, and we thought they'll be coming and announcing. And maybe I request Dr. Selvaraj to come and announce. And once again, thank you, everyone. Have a nice time. Let us keep in touch. Thank you very much.
Thank you for the wonderful address, sir. May I now request Dr. Nagendra R. Sir, Joint Organizing Secretary, ARDSICON 2025, to present the vote of thanks.
Good evening to one and all. Seeking his blessings from the lotus feet of Sri Jagadguru Shivaratrishwara Swamiji. It's my immense pleasure to propose vote of thanks on this auspicious occasion on behalf of ARDSI Mysuru chapter, Department of Geriatrics, JSS Hospital Mysuru, Sharda Vilas College of Pharmacy, Mysuru. I would like to extend my thanks to Renu Vora ma'am, Chairperson, ARDSI New Delhi. Thank you, ma'am. We extend our gratitude to Dr. Pratibha Perera Madam, Head, Department of Geriatrics, JSS Medical College, JSS Academy of Higher Education. Thank you, ma'am. Our heartfelt thanks to Dr. Anamantachar Joshi sir, Chairman, LOC ARDSICON 2025, Principal, Sharda Vilas College of Pharmacy, Mysuru. Thank you, sir. Special thanks to all the delegates, organizing committee members, student volunteers, venue technicians, press and media personals. Thank you one and all who are directly and indirectly involved in successful completion of this event. Thank you one and all.
Thank you, sir. I request the gathering to kindly stand for the national anthem.
Before we begin national anthem, a special thanks to Pratiksha and all the volunteers here. I think we all should give a big round of applause for her. Thank you, Pratiksha, Disha. I don't remember most of your names, but I think they have worked the most. And I acknowledge this moment I take to acknowledge our postgraduates, because we all were here. It was the postgraduates who were running the show. Thanks to you also. Thank you very much.
With this, we have come to the end of the ARDSICON 2025 International Conference on Dementia, Policy, Practice and Progress. As we conclude this event, let us carry forward the knowledge gained, the friendships formed, and the inspiration ignited. As we part ways, let's not just remember this event, let's use it to inspire what comes next. Thank you, one and all. Have a great day. I request the gathering to kindly gather in front of the stage for a group photo session. I repeat, I request the gathering to kindly gather in front of the stage for a group photo session. I request the gathering to stand near the chairs present in the front of the stage for a group photo. I request the gathering to stand near the chairs present in front of the stage for a group photo.